Good morning, everybody, and welcome to the Osher Center for Integrative Medicine Grand Rounds. My name is Peter Wayne, and I serve as the director for the Osher Center. Today, we're going to mix things up a bit and use this Grand Rounds to showcase the work in progress of 3 of our current postdoctoral fellows. All 3 are actively enrolled or have recently completed the Harvard Medical School Research Fellowship in Integrative Medicine, which is based at BIDMC and led by Dr. Gloria Ye, who's also Osher Center's Director of Clinical Research. The fellowship is the longest standing T32 training program supported by the National Center for Complementary and Integrative Health at NIH. As you'll see from our presentations today, the research being pursued by our fellows is well aligned with the broader research agenda of the Osher Center, spanning the full spectrum from basic to community-based research and addressing important scientific questions as well as social issues. Before introducing our speakers, just a few housekeeping notes. First, if you wish to request CMEs, please be on the lookout for a note in the chat feature of Zoom that will provide some detailed instructions. Second, as you listen to the presentations today, we encourage you to submit questions for our speakers using the Q&A feature. I'll be collating these and presenting them to our panelists in the discussion following all 3 presentations. So now it's my pleasure to introduce our first fellow, Dr. EunMee Yang, or Amy Yang. Dr. Yang graduated from our fellowship last year in 2022. Her prior training includes a PhD in acupuncture from Nanjing University of Chinese Medicine, a master's in acupuncture and Oriental Medicine from Virginia University of Oriental Medicine, another master's in the Physiology of Complementary and Alternative Medicine from Georgetown, and prior to all that, a BS in Biology from MIT. The primary focus of Dr. Yang's research is understanding the physiological basis of acupoints and mechanisms of action underlying acupuncture efficacy to ultimately inform practice and optimize acupuncture treatment outcomes, which he is currently pursuing at the Osher Center. The title of her presentation is, "What is the Point? Exploring the Physiological Basis of Acupuncture." So without any further delay, I'm going to pass this on to Dr. Yang.
Can you see my slides? Okay, great. So thank you for that kind introduction. So again, the title of my presentation today is "What is the Point? Exploring the Physiological Basis of Acupuncture Points." And as the title suggests, and as Peter introduced, my research is focused on this question of what are acupuncture points. And this is a question that I've had for a long time as both a practitioner and researcher of acupuncture. So I'm excited to share with you some of my work related to this question. I'll begin with the brief background to provide some context for understanding the significance of this question. And then I'll share 2 of my projects, mostly focusing on their conceptual framework aimed at addressing this question. So first, the background. To make sure that we are all on the same page, I'd like to start with the definition of acupoint. So acupoints are specific locations on the body that are needled and stimulated in acupuncture treatment. There are about 360 acupoints on the body, and they're located on what we call the 14 channels and meridians. And these meridians are represented by lines on the figure. And as an example, an acupoint called LI4 is located on the large intestine meridian. It's the 4th point on that meridian. And another example, ST36 is located on the stomach meridian, and it's the 36th point on that meridian. These are probably the 2 of the most common acupoints used in research and practice. The main takeaway message from here is that acupoints are considered a key defining feature of acupuncture. And the concept of acupoint or point specificity or selectivity is central to the theory and practice of acupuncture. So let's now discuss the problem. So this is a 2018 commentary by Dr. Langevin and Dr. Wayne entitled, "What is the Point? The Problem with Acupuncture Research That No One Wants to Talk About." And here they note that despite remarkable recent progress in basic and clinical research, the subject of whether or not acupoints exist remains largely avoided within the acupuncture research community. And so far, no anatomical, histological, or biochemical measurements have conclusively demonstrated systematic differences between acupoints and non-points. So as pointed out by this commentary, the field of acupuncture research has indeed grown and progressed significantly in the last few decades. However, there are fundamental knowledge gaps regarding the scientific basis of acupoints, which ultimately impacts our understanding of acupuncture as an evidence-based therapy. So there have been many RCTs or randomized controlled trials comparing efficacy of acupuncture administered at acupoints and sham points or non-points, and the findings have been mixed and conflicting. But the more fundamental issue is that given the lack of scientific clarity regarding acupoint, there is substantial variability in point selection across studies, and this makes it really difficult to interpret findings and synthesize evidence across studies. And so to really move the field forward and appropriately address this question, does point selection matter? It will be important to address this knowledge gap regarding acupoint. So I'd like to transition now and share two of my projects. The projects are still in the early stages, so I'll be focusing mostly on their conceptual framework. And in developing my conceptual framework, my approach has been to incorporate insights from traditional theories and practice of acupuncture on one hand, and from basic animal research on the other. And the first project involves this concept of acupoint sensitization. According to the concept of acupoint sensitization, it's believed that disorder of visceral conditions and organ is reflected in acupoints. So in other words, it's theorized that the status of acupoints are dynamic and that they can change from a silent to an active state during pathological processes. And furthermore, it's theorized that stimulating sensitized acupoints exert a better therapeutic effect than stimulating non-sensitized point. So based on this theoretical premise, in clinical practice, many acupuncturists often palpate the patient's body to identify tender points for both diagnostic and therapeutic purposes. And there's been an emerging body of basic animal research supporting this concept of acupoint sensitization. These studies suggest that cutaneous hypersensitivity on certain locations of body surface might serve as an indicator of pathological conditions and corresponding visceral organ. And this is an example of one study. In this study, the investigator created or established experimental rat models of colitis, and then they intravenously injected the rats with Evans blue dye to visualize and identify locations of cutaneous neurogenic inflammatory spot, as indicated by these blue dots on the figure. And they found that these neurogenic inflammatory spots correspond anatomically to locations of many classical acupoints. What was interesting and exciting about the study is that they further showed that intestinal inflammation was better attenuated by acupuncture needling at one of the sensitized or blue spot versus a nearby non-sensitized spot. So altogether, putting together theory, practice, and prior animal research, the conceptual framework is that there's a bidirectional link between visceral and cutaneous pathophysiology. And I propose that clarifying how cutaneous physiology is affected by and affects visceral pathophysiology through this bidirectional link may be important in developing a mechanistic understanding of acupoint. Of course, it will be important to translate this animal research and investigate the validity of this framework in human, and so that is one of my long-term research goals. And as a first step, I'm conducting a pilot study, an Osher-funded pilot study, to begin to explore the first part of this bidirectional link, whereby of how visceral pathophysiology may lead to acupoint sensitization. I'm using IBD, or inflammatory bowel disease, as the disease model, given a number of prior animal research using experimental models of colitis. The target sample size for the study is 30 IBD patients and 15 healthy controls. And I'm using biophysical properties as proxy measures for acupoint sensitization or cutaneous neurogenic inflammation. And these properties include blood perfusion, temperature, and pressure pain threshold. The primary aim is feasibility of recruitment, retention, and data collection procedures. But for secondary aim, I'm interested in measures of variability to inform future Foley power size, comparing these biophysical properties in individuals with and without IBD. These are the tools that I'm using to collect the biophysical measures. I'm using laser spectral contrast imaging for cutaneous blood perfusion, infrared thermography for temperature, and algometry for pressure pain threshold. The study is ongoing, so I don't have complete data to share with you, but I'd like to give you a sense of what the measures of cutaneous blood perfusion looks like. So we collected measures of cutaneous blood perfusion at different body regions, including the lower leg. And here's an image of the lateral side of the upper half of the right leg, and the corresponding blood perfusion images. And in the dotted circle is the approximate location of Acupoint ST36. We also collected images of the ears, and this is image of the right ear and the corresponding blood perfusion images. Hopefully I will have the opportunity to share the full data in future presentations. But moving on to project 2. The project 2 involves better understanding the local physiological effects of acupuncture needling at acupoints. And so acupuncture needling induces a flare response or arrhythmia around the needle site. And according to traditional theories, acupuncture-induced flare is often viewed as a sign of a positive clinical outcome. And there's been an emerging body of basic animal research suggesting that local physiological effects such as activation and degranulation of mast cell may play an important role in mediating the analgesic effects of acupuncture. The key findings from these studies is that first, there's a higher density of mast cell at acupoints compared to sham points. And second, acupuncture needling induces mast cell degranulation and release of various vasoactive mediators. And third, inhibiting mast cell degranulation reduces the analgesic effects of acupuncture. So putting together, again, the theory and prior animal research, the conceptual framework is that acupuncture needling induces local physiological effects, which may in turn be associated with acupuncture efficacy. And I propose that understanding this conceptual framework may be important in developing a mechanistic understanding of acupoint. So again, in this project, it will be important to validate this model in human, and that is one of my long-term research goals. And so as a first step, I recently submitted a career development grant proposal aimed at characterizing the local physiological effects to acupuncture needling at acupoint LI4 compared to sham points of the same hand. And then for the local effects, I'm interested in measuring changes in cutaneous blood perfusion in response to needling using laser spectral contrast imaging that you saw earlier. And then as for acupuncture efficacy, I'm interested in using experimental pain models, specifically capsaicin-evoked pain model in healthy volunteers. And capsaicin-evoked pain model is a well-established pain model for neuropathic pain. And so again, this is a proposal, so I don't have data to share, but I want to show you a sense of what the data looks like for local changes in cutaneous microcirculation in response to acupuncture needling at LI4. So here's an image of the left hand and the corresponding blood perfusion images in response to acupuncture needling at this point, LI4. And the white arrow on the images indicate the location of the acupuncture needle. It will be interesting to find out whether the flare response varies with point location and whether or to what extent the flare response is associated with acupuncture efficacy. And as you can see, there is changes in the flare size and intensity across time. And so it will also be interesting to do a spatial temporal analysis. And also, I'm interested in how different acupuncture parameters such as needling depth and manipulation also affects the flare response. So in conclusion, one of the major knowledge gaps in the field of acupuncture research is a lack of scientific clarity on what acupoints are. And the overall goal of my research, or the point of my research, is to advance mechanistic understanding of acupoints using standardized tool and by integrating insights from both theory and practice of acupuncture on one hand, and from basic science or animal research on the other. And as both a practitioner and researcher of acupuncture, my ultimate goal is for my research to inform clinical practice and potentially contribute toward evidence-informed point selection, as well as refinement of other acupuncture parameters to optimize acupuncture treatment outcomes. So I'd like to acknowledge and thank the Osher Center for funding the pilot study, as well as Dr. Korsnick and the Crohn Center for helping with the IBD patient recruitment. I'd like to also thank all of my mentors, collaborators, and colleagues from the Osher Center, the Dana-Farber Cancer Institute, where some of my other projects are based at, and of course the T32 Fellowship. And thank you so much all for listening.
Thank you, Amy. That was fabulous. What a great presentation. So our next speaker is Dr. Michael Datko. Dr. Datko is a current fellow pursuing mind, body, and neuroimaging research with mentors based at the Cambridge Health Alliance and Mass General Hospital's Martino Center for Neuroimaging. Prior to joining our fellowship, Mike obtained his PhD in cognitive science from UC San Diego and his bachelor's degree in science in biopsychology from UC Santa Barbara. The title of Dr. Datko's talk today is Changes in Interoception and Emotional Regulation. Emotion regulation drives effects of mindfulness-based interventions for patients with anxiety and depression. So Mike, thanks for presenting today. It's all yours.
All right, thank you, Peter. So, hi everyone. My name is Michael Datko. I'm a postdoctoral researcher with the Center for Mindfulness and Compassion at CHA, and I'm a fellow with the Osher Center. So, like Peter said, I have a PhD in cognitive science from UC San Diego. I've been interested in meditation for a very long time because I grew up around meditators, including my parents who were or are meditation teachers. I was also always very interested in how physical changes in the brain, either from behavioral or pharmacological sources, can impact our cognition, our consciousness, and our mental health in profound ways. Over time, these two interests of mine merged and led me to the research that I'm pursuing today, and I've been working on as a fellow in the Osher Center. So today I'm going to talk to you about a couple different studies looking at the neural mechanisms by which mindfulness-based interventions can impact patients with anxiety and depression. Both of these studies were done as sub-studies of a larger trial that was completed over several years at the Cambridge Health Alliance Center for Mindfulness and Compassion. This study of mindfulness training for primary care patients examined several behavioral and clinical outcomes related to behavior change and chronic disease self-management. So mindfulness training for primary care is an 8-week trauma-informed mindfulness-based program designed for primary care patients to enhance chronic illness self-management, as well as reduce stress, anxiety, and depression while motivating health-related behavior changes. MTPC is designed specifically for primary care patients with anxiety and depression. The studies on this intervention compared participants who were randomized to either the active MTPC intervention versus those who were randomized to a low-dose comparator condition, which included a single brief mindfulness session followed by a waiting period. One of the primary outcomes of this larger trial is called action plan initiation. And this is a measure of to what extent participants were able to initiate a plan they laid out for themselves towards the end of the intervention, with the goal of laying out specific steps and behaviors related to health or self-management. The study of MTPC was completed in 3 phases between 2016 and 2020, and each phase showed that MTPC participants had higher odds of successful action plan initiation compared to the control participants. So we learned from this work done by many colleagues at CMC that MTPC can have a positive impact on behavior change among patients. And that led us into asking why or how it was able to have these effects. So self-regulation and interoceptive awareness are key targets for mindfulness-based interventions, or MBIs. The neural mechanisms of MBIs for anxiety and depression are not well understood. Understanding those mechanisms not only gives us a more complete picture of how interventions such as MTPC work, but may help us design more effective interventions in the future. So to examine the possible neural mechanisms underlying MTPC's effects, we conducted 2 sub-studies using functional magnetic resonance imaging, or fMRI, which allows us to see changes in blood flow in the brain, either spontaneously or during specific tasks. The first study that I will talk about used an evoked pain task in which participants' brain activity was measured during the anticipation and the actual experience of a painful stimulus. This allowed us to focus on neural mechanisms of emotion and pain regulation, including the medial prefrontal cortex, the insula, and the somatosensory cortex. The second study used an interoceptive attention task in which participants focused on their heartbeat, allowing us to look at brain mechanisms of interoception, such as the insula. So the capacity to regulate and manage affect and emotion is an essential component of behavior change. Affect regulation in the context of aversive or stressful experiences is important to maintain resiliency and to be able to initiate behavior changes related to chronic illness self-management when living with conditions such as depression and anxiety. The medial prefrontal cortex is a critical hub for the coordination of autonomic, affective, and behavioral responses to the anticipation of stress and aversive experiences, including pain, for example. Patients with depression have shown lower activation in the medial prefrontal cortex, while also showing higher activation in pain processing regions, such as the anterior insula, during pain and the anticipation of pain. So the anticipation of pain in particular can be a proxy for the anticipation of other stressful or aversive experiences. We hypothesized that following MTPC, patients with anxiety and depression would show reduced fMRI brain response to both pain and pain anticipation in somatosensory cortex and insular cortex, which are involved in the processing of pain. We also hypothesized that, that is the insula. We also hypothesized that patients would show increased brain response to pain anticipation in medial prefrontal cortex, which will be associated with higher action plan initiation, which is our measure of behavior change that I talked about before. So for this sub-study, we took some participants who were already enrolled in the larger trial. We took a subset of those who were randomized to the active MTPC group. And if they were interested and qualified, they could participate in this fMRI sub-study. And if they did, then they completed a baseline MRI in which they did this pain task that I'll talk about soon. Then they completed the actual MTPC intervention, which is 8 weeks of instructor-led group sessions, as well as daily practice of at least 30 minutes per day. During week 7 of the intervention, each participant created an action plan, which is basically a concrete set of steps and sort of a timeline for steps they're going to take each day or each week to help them manage their chronic self-manage their chronic illness. And so after the intervention, they completed a post-intervention MRI visit, and at that time, they also assessed the extent to which they completed their action plan, to the extent to which they followed through on that. And so a total of 19 participants completed all of this, as well as the scans for this sub-study. So for the actual scans, participants completed a 6-minute evoked pain task while having their brain scanned with fMRI. And this task involved a few main conditions, one of which was a cuff pressure stimulus, in which we basically put a blood pressure cuff around their left calf and inflated that to a level that each participant rated as a moderately painful stimulus. So about a 40 out of 100 on a pain scale. So we evaluated the brain response to pain minus a rest period and also this period of pain anticipation minus rest. And so the anticipation period was basically this plus sign that is shown on the screen during rest turns green for a variable amount of time to show the participant that pain is about to come, but it's not there yet. So we really focused on that period in some of our analysis. We also compared baseline to post-intervention time points for both of these conditions. And we modeled the association between action plan initiation, our measure of behavior change, and the post-intervention changes in brain response to pain anticipation. So at baseline, the response to the pain condition showed activation in areas that we expected that are associated with pain processing, including the bilateral insula, which you can see here, as well as somatosensory cortex, shown here. Similar results were shown at baseline for the pain anticipation condition, also saw activation in the insula and in somatosensory cortex. Following training, we saw that there was a reduction in activity in response to pain anticipation in frontoinsular cortex, which you can see here. So this was in line with our hypotheses that basically there's less processing in these pain processing regions after MTPC. So we're also interested in whether this was associated with behavior change. And what we found is that in a whole brain test, we found that there was a cluster of voxels or three-dimensional pixels in the medial prefrontal cortex, which is shown here, that during pain anticipation is associated with higher action plan initiation. So the change in that region during pain anticipation from baseline to post-MTPC treatment, that was associated with how much each participant was able to initiate their action plan. So this shows that medial prefrontal cortex is a neural mechanism for the improved capacity to maintain goal-directed behavior in the face of challenges and aversive experiences, and we use pain as a proxy for that experimentally. So our findings suggest that mindfulness training programs that are specifically designed for anxious and depressed patients can impact brain mechanisms related to emotion and pain regulation and enhance the capacity to initiate behavior change. So moving on to the second study that I'll talk about today, depression and, interoception. Interoception is the perception of signals originating from within the body, such as the heartbeat or lungs during respiration, internal temperature changes, and so on. And the insula is typically associated with tasks where participants are asked to pay attention to these sensations. So the insula is a hub for interoceptive processing as well as pain processing. And so dysregulated interoceptive awareness in various forms has been observed in depression and anxiety, including reduced activation on tasks that activate the insula. And our group, as part of the main MTPC trial, Julie Dunn led this study looking at baseline measures of interoceptive awareness, one of which is body trust. So it's a measure of how much someone trusts the sensations that are coming from their body and trust those signals and can pay attention to them. And so body trust is lower in people with more severe depression in the sample that we studied. So we hypothesized that following MTPC, we would see increased insula response during an interoceptive attention task, and that would be associated with increased body trusting and associated with or linked with depression severity. So in this task, which was also completed before and after MTPC, participants completed a 10-minute task in fMRI in which the main conditions were interoception, in which they were paying attention to their heart, sensations that they could feel from their heart, their heartbeat, versus exteroception, which is basically just looking at a word on the screen and watching it change from uppercase to lowercase. It's a very simple, just kind of an external stimulus that we ask them to pay attention to. And so we contrasted the activity between the interoceptive and exteroceptive conditions, and we compared that from baseline to post-MTPC intervention. We also modeled the association between a few different variables between depression severity groups, so people that had either mild or none depression, mild or no depression, or moderate to severe depression. We also looked at that with the association with changes in insular response to interoception before and after the training, and changes in body trust before and after the training, as measured by the multidimensional assessment of interoceptive awareness, which is a common questionnaire that's used. Okay, so our results in a whole so we looked at every training, we saw a difference, we saw an increase in activation during this task, specifically in the insula, and so that was in line with our hypotheses. This is a view of the percent signal change for each participant before and after training, and that was a significant difference. So based on scores on the PROMIS, which is a clinical questionnaire designed to measure depression and anxiety symptoms, all the participants in our study had at least moderate levels of anxiety. However, with regards to depression, the participants in our sample fell into either of two subgroups based on their depression severity. About half were moderately to severely depressed, and the other half had mild or no depression based on the PROMIS score cutoffs. So also recall that body trusting is a component of interoceptive awareness that we identified as being lower in more depressed individuals. So we were interested in looking at how that was associated with activation in this task. So we modeled the association between depression severity group, post-intervention changes in insular response, and post-intervention changes in body trust. And we found that depression moderated the association between post-training change in body trusting and insular response to interoceptive attention in this region in the anterior insula, which is in line with our hypothesis. Examining that association further, we found that the moderate to severe depression group had a positive association between change in body trust and change in insular response to interoception, while the group that only had anxiety, so everyone in the sample had anxiety, but the group that did not have comorbid depression had an inverse relationship between those two variables, as you can see here. So we found increased insular response to an interoceptive attention task following MTPC, and that was associated with increased body trusting among those with anxiety plus moderate to severe depression, but not among those with anxiety alone. And so this kind of indicates that mindfulness-based interventions, their effects on mechanisms of interoception for patients with anxiety could change based on whether they also have comorbid moderate to severe depression. There's a number of reasons why this might be the case. Depression has been associated previously with hyposensitivity to interoceptive sensations, whereas anxiety is often associated with a hypersensitivity to interoceptive sensations. So overall conclusions from this work, we found that MTPC initiates behavior change via neural mechanisms of self-regulation. And we found that MTPC acts differentially on neural mechanisms of interoception based on symptom severity of each participant. So this could represent a step towards using mindfulness-based interventions and developing them as tools for precision psychiatry interventions. And in future work, we could investigate how individual differences in other clinical factors may predict patients' responses to MTPC or other mindfulness-based interventions. So thank you very much. This is the study team who did the main trial and helped with the fMRI work. And yeah, thanks to everyone in the fellowship for supporting me. And yeah, thanks for listening.
That was fabulous, Mike. Thank you. So our final speaker for today is Dr. Jacklyn Foley. Dr. Foley is a current fellow and a licensed clinical psychologist with research interests related to developing and evaluating mindfulness-based therapies for people living with or at risk for HIV. Prior to joining our fellowship, Dr. Foley received her PhD from Syracuse in clinical psychology and a bachelor's in psychology from Brown University. The title of her talk today is developing integrative behavioral interventions to promote the health of older people with HIV. So Jackie, it's all yours. Thank you.
Hey, thank you, Peter. So just to give a brief outline for my talk, Peter just very nicely gave that introduction, which included its title. I'm going to provide a brief background on HIV and specifically people aging with HIV, which should provide a nice foundation to discuss two studies. The first is called My Heart, which is a Harvard University Center for AIDS Research Developmental Award, in which data collection has just begun. And the second is a K23 application that will likely be resubmitted to NHLBI. And I have my mentors on each of those projects listed there. So I'll start today by saying that the HIV epidemic has changed rather significantly across the decades. HIV went from being an acute, often fatal infection to now a chronic disease that people are living with for decades. And the greatest contributor to that change was in the late 1990s. You can see my precursor here. We had the introduction of highly active antiretroviral therapies. So these are the HIV medications that people have now been taking. And you'll see here in the graph below that right around this time, we saw newly diagnosed HIV or AIDS cases going down and also people living with HIV significantly going up. And that is really where my talk is going to be today. With these people living longer and longer, we've had more time to understand the long-term impact of living with HIV, which has included rather significant increases in multi-morbidity, seeing much more things like frailty and cognitive decline at much lower ages than we see for the general public. And so it's really been a big focus across NIH institutes focused on HIV/AIDS research and to understand and better the health of people aging with HIV. And where I'm going to focus on today is on one specific comorbidity, which is cardiovascular disease or CVD. And the reason for that is because people with HIV are disproportionately affected by cardiovascular disease, such that you see really high increased risk of things like acute myocardial infarction or heart attacks, heart failure, ischemic stroke, coronary heart disease. All of these things are contributing to more than doubling of the proportion of deaths in people with HIV attributable to CVD. So what we're really seeing is that people with HIV are no longer dying from HIV, they're dying from other things, and CVD is a major contributor to this. The pathophysiology underlying this HIV-CVD comorbidity is rather complex. And truthfully, a lot of these pathways I'm showing here are only hypothesized. There's a lot of interest in really elucidating and confirming why this comorbidity exists. But generally, I think there's some consensus that there are some of this pathophysiology kind of driven by the HIV infection itself. So you can think of living with this long-term immune dysregulation, even if it's low grade, because most often people are treated with medications, but still that's still there, and it's driving kind of this consistent chronic, even though it might be low grade inflammation, which is going to have all of these downstream pathophysiological effects that are going to make a person living with HIV more susceptible, if you will, to. But there's also quite often report higher behavioral CVD risk factors. So for example, people with HIV are much more likely to be tobacco smokers than someone who is not living with HIV, just as one example, which of course, I think no one's going to argue, of course, also leads people to be at increased cardiovascular disease risk. What often is like less studied or maybe less appreciated in the CVD risk reduction literature is the role that psychological distress has to play. So people with HIV often report elevated psychological distress, which I broadly define as being inclusive of both psychological disorders and subthreshold, say, anxiety and depressive symptoms. And that is likely both as a function of living with HIV when we think about how stigmatized that identity is in conjunction with often a lot of other identities that these people hold. So for example, being a sexual or gender minority, being a racial or ethnic minority, and so on and so forth, but also likely predates the HIV infection. So, we know that these rates are higher, and there's also good evidence to show that psychological distress can exacerbate inflammation in the body via both biological and behavioral mechanisms. So biologically, we know psychological distress activates the immune response, the sympathetic nervous system, and the HPA axis. But also behaviorally, psychological distress often drives a lot of CVD risk behaviors. So things like tobacco smoking, hazardous alcohol use, sedentary behaviors, and poor diet quality. If we take depression, for example, quite often people will use things like cigarettes and alcohol use as a way to cope with that depressed state. But also that depression can create a barrier to engaging in health behavior change, kind of what Mike was talking about in his talk. And so both biologically and behaviorally, psychological distress is actually very important when we're thinking about heart health in people with HIV. But so often it's not incorporated in CVD risk reduction interventions. So I would say, there's been very large meta-analyses showing, across CVD risk reduction strategies or different intervention programs, we know that things like lifestyle modification or behavior change are important, and no one's arguing that to reduce CVD risk, people are going to be better if they quit smoking, if they engage in 150 minutes of moderate or 75 minutes of vigorous exercise each week, if they adhere to like a Mediterranean or DASH, which is basically a low salt diet, limiting alcohol use and other substance use. But quite often what these interventions also say is we should address things like depression, stress management, and quality of life concerns, but there's not often recommendations on best practices and how we should do that. And so it's not surprising then, at least to me, that these risk reduction interventions have so far only shown modest efficacy for people with HIV. So they're just not working very well, or as well as I think that they can. And so we take something like the diabetes prevention program, which has shown a lot of promise specifically for people with HIV and the general population when you look at improvements in systolic blood pressure, cardiorespiratory fitness scores, and even showing some anti-inflammatory effects, although that has not been shown in people with HIV. Our group has also already done some formative work to adapt this specific program for women with HIV. So this line of research, I'm really building on the foundation within the behavioral medicine program at MGH. But still, there's some work that needs to be done, even with a program that shows so much promise. So I think CVD risk reduction interventions like DPP would likely be significantly improved by including evidence-based strategies for targeting psychological distress to reduce inflammation, but also to support the implementation of lifestyle recommendations or engaging in behavior change. One way that I think we can do this is by looking at mindfulness practices. So mindfulness-based interventions have already been shown to be efficacious at reducing psychological distress, both among people with HIV and people with CVD, none with people with both, but that should be coming. I'm actually working on that meta-analysis. And they've also been shown to be efficacious at reducing these biological and behavioral mechanisms linking psychological distress to CVD. So biologically, again, we have, nervous system activation, immune response, and inflammation. And behaviorally, we have all these CVD risk behaviors, things like tobacco smoking, alcohol use, physical inactivity, and poor diet. So it's my hypothesis that mindfulness could be an integral intervention component to address CVD risk among people with HIV that addresses multiple and overlapping biological and behavioral mechanisms, which leads me to discuss my two projects that fit within this conceptual model. So the model being, that if you take a mindfulness-based intervention, like, for example, mindfulness-based stress reduction or MBSR, you get people to engage in mindfulness practices. They learn better self-regulation, which is encompassing both, my ability to attend and have control over what I am attending to, my ability to regulate my emotions, and metacognitive awareness, which is really my ability to be aware of and observe my ability to do all of these things, like regulate my emotions, control my attention, so on and so forth, is going to help reduce psychological distress, help people to engage in fewer CVD risk behaviors, which is then going to have downstream effects on immune activation, inflammation, and therefore CVD risk. But how do we test this? That's where a lot of my research comes in. So my heart, again, is my Harvard CFAR Developmental Award. It stands for Mindfulness, HIV, and Heart Health. It's a convergent mixed method study, meaning simultaneously we are going to be collecting both qualitative and quantitative data. Qualitatively, we're going to be conducting focus group discussions, and quantitatively, we're going to be asking people to complete surveys. And what I think is really interesting and unique about this project is we're also going to be having everyone undergo blood draws, which is going to allow us to assay for some key inflammatory biomarkers, specifically in this project, IL-6 and CRP. And ultimately, this data is going to help us describe people with HIV's experience of psychological distress and specifically how it impacts their cardiovascular health, identify strategies to reduce psychological distress that would also help their cardiovascular health, which is going to include assessing the potential for an effective mindfulness on inflammation, which is only possible because we are collecting those biomarkers, as well as more generally identify barriers and facilitators of maintaining cardiovascular health. The second project, which is my K23 application, is called One Mind, One Heart, and that goal is really to refine and synthesize evidence-based content from MBSR and the Diabetes Prevention Program, or DPP, to develop and pilot test this new intervention called One Mind, One Heart, based on the Orbit model. The aims are threefold. The first is to refine DPP and MBSR in terms of content, delivery, and dose to really develop One Mind, One Heart. We'll use qualitative feedback from semi-structured interviews with older people with HIV in psychological distress, and also solicit feedback from really experts in the field, including psychology, infectious disease, and cardiology providers. We're going to take all of that formative qualitative work, refine kind of our packaging of the new One Mind, One Heart intervention, and then we're going to explore the initial acceptability of One Mind, One Heart in the study methods in an open pilot that will include exit interviews and pre-post assessments. We're going to do some further refinement, and then aim 3 is going to be evaluating benchmarks of feasibility, acceptability, and potential for effects on inflammation and CVD risk behaviors in a pilot RCT. So really, the K builds on this conceptual model to include DBP and thinking about the behavior change aspect. You know, when we improve or increase things like education, motivation, and the skills, might we also be able to move the needle on some of these downstream processes that are leading to greater CVD risk in this population. Just to provide a little bit more context for the K, this is kind of how it will happen by different phase. So happy to take any more questions about that, but I outlined that pretty thoroughly in the aims. And I kind of, in addition to the biomarkers, which I think makes this work very interesting, I also find the intervention to be quite significant. So I thought I would preview a little bit. This is, of course, can change, you know, because it is reiterative and we are getting feedback on each of these components. But generally, One Mind, One Heart is set to be an 8-session intervention where everyone will get the first session, which is primarily education. And the idea is that we're fusing both the DBP content and the MBSR content, and then we're adapting or adding new content to be relevant to the population. So for example, if we take session 1, in DPP, this is all education on cardiovascular disease and its risk factors. We would be proposing to add new content that really gets at the increased risk people with HIV are at for cardiovascular disease, including higher rates of substance use, but also including some of those more biological or pathophysiological processes that I discussed earlier. And, you know, you could go through and kind of peruse all of the other sessions, but again, the idea is, can we increase the efficacy of DPP for this very specific population by fusing it with mindfulness-based content from MBSR and also adapting it to really meet the very specific needs of people with HIV? Another really, I think, cool and interesting part of One Mind, One Heart is there's also going to be this kind of techie piece where we're also going to be doing bidirectional text messaging with folks. We found in some other formative work that it can sometimes be hard for this unique and vulnerable population to attend several in-person sessions. And so, the group that I work with has been experimenting with this idea of, can we increase the dose of these interventions by engaging in this bidirectional text messaging. So the real intention of these text messages are to remind them of the intervention content they were exposed to in the 8 sessions. So for example, a prompt around psychological distress might be like, are you feeling down, stressed, or at all negative today? And if they say yes to that, it will encourage them to engage in one of the mindfulness-based practices they were taught in the intervention. So in this case, a 3-minute breathing space. If it were a physical activity prompt, it might say, have you walked at least 10 minutes or got another physical activity today? And if that were a no, it just might encourage them, prompt them, remind them that they could take a 10-minute walk. So overall, the impact I see this line of research having is, of course, I want to help improve the health of the more than 1.1 million people aging with HIV in the United States, both their cardiovascular health and beyond. But I also think we need a better understanding of the pathophysiology of this HIV-CVD comorbidity. As I described earlier, these things are hypothesized, but they're not known. And so what is truly going to work in terms of an intervention will remain unclear until we have this better understanding. And so I also think this line of research will help us to understand the mechanisms of mindfulness-based interventions that are aimed to mitigate these pathways. So thank you. Thank you to the T32. Thank you to the Osher Center. Thank you to my collaborators and mentors, one of whom is Gloria Ye, shown here. So thank you, everyone.
Thank you, Jackie, and what a great picture to end with. And thank you all for such rich and inspiring presentations. It's really nice to know that the future is in good hands with this new generation of really bright and motivated and ambitious scientists. So we don't have a heck of a lot of time. I'm going to try to ask a question of each of you. There's lots of questions online coming in and other ones coming through my text. But I'm going to start with Amy. I'll just start with one question for each of you. So you're talking about some biological phenomena that's happening at acupuncture points. 2 questions around that. One is, I know that from working with you that you work in cancer populations, you're having this IBD study going on, and you're looking at experimental pain. Do you think that the signature of the activation of these points, either with inflammation or other markers, is disease specific? In other words, the way that these points do or don't light up would be different for someone with cancer or different kinds of cancer versus bowel disease?
I think, so in clinical practice, I do a lot of channel palpation to identify these, what we call active points, to kind of better understand what's going on internally. But to answer your question, I think we're still very early stage of research to really answer that question. But that's what I'm hoping to kind of begin to explore through my research. And, from a biomedical perspective, we know that there's a convergence of cutaneous and visceral afferents in the spinal cord. And so there is some biological explanation or neuroanatomical explanation for why certain body regions or certain points, locations on the body could be sensitized and be active. But to really differentiate, can we differentiate someone with a IBD versus just a day of diarrhea or constipation or GI issues? I'm not sure. And so, and this is what we're hoping to really achieve through our research.
Super. So there's some question about personalized medicine there. Maybe the markers of one person with a certain set of morbidities is slightly different than another.
Exactly. So, the way acupuncture research is conducted right now, the research is focused on measuring systematic effects of acupuncture and not really so much what happens locally. And so by understanding what happens locally, we may be able to, pick the right points. And that's the hope, but we're still kind of scratching the surface at this point.
Good. Well, thank you. So I'm going to just follow with that thread of personalized medicine and the uniqueness of individuals within populations and ask Michael a question, which, I think it's intriguing. At the end of your talk, you're sort of opening up this whole world of personalized mind-body psychiatry. And, you have such dramatic different responses in terms of interoception for people with depression or without in the presence of anxiety. Can you just unpack that a little bit? I mean, do you think that, so your parents are meditators and they watched you become a geeky scientist and really deep dive into this work. What would they say? Do you think that people with different psychological predispositions should be practicing different kinds of meditation? And is there a risk for certain people for doing meditation if they come in with a certain condition versus another?
Yeah, I don't know exactly what they would say, but I basically I think that not everyone, different people gravitate towards different practices. So there's preference, I think, plays a large role in how much you get out of a particular kind of practice. So you can't sort of force the practice of mindfulness as it's taught in MBSR onto everyone. It's just not for everyone. And so some people really connect with that, and that might be for personality reasons, which might be a little harder to study, or it could be because of quantifiable clinical variables that we can study. So I'm sort of interested in both of those, but it's just easier to study the variation that comes from variables that are really well quantified. So that's what I'm really interested in.
Yeah, and as you know, we can unpack this later, hopefully, but there's big differences between seated mindfulness meditations and movement-based, and given you're interested in interoception, that there might be some really opportunities there to personalize the path that people get this training based on their disposition. So Jackie, in 1 minute, you're studying this very important and vulnerable population, people with HIV and this aging population, which is like a whole new domain. I mean, this has never been possible due to the fantastic progress in pharmacological treatments and other treatments. What have you learned that, working in this unique population about the potential need to adapt programs for specific populations, which seems to be a big part of your work?
Yeah, I'm glad you asked that question, because I was going to ask to answer the question posed to Mike as well for this reason, because I think packaging is so important. I think in our work, I think everyone here knows mindfulness can be very powerful in a lot of different ways for improving health. But I think when you're working with this particular population and others that I work with as well, particularly people who use substances, you have to meet their more immediate structural needs first. So quite often you're working with people on very basic skills on how to get access to things like housing and food before they'll even engage in a conversation of the benefits of something like mindfulness. So I think that's been proven to be really important, as well as having, as Mike was alluding to, options. I think quite often people that I work with don't have the time or interest in sometimes the flowery, non-concrete kind of language that goes along with different formal mindfulness-based practices. So quite often when I'm working with people, it's about, can you just mindfully observe when you're doing things like washing the dishes? And that moves and goes over a lot better with people. So those are just kind of two things that come top to mind.
Thank you. And we can just go round and round. I wish we could for hours, but I need to wrap things up. So thank you to the three of you for your work and commitment and your great presentations. Two final announcements. First, we hope that you'll join us next month for our grand rounds on the 4th, Tuesday the 4th. The title of the talk is Integrative Aging, Better Health Across the Stages of Old Age. And this is a lecture that's going to be presented by a renowned Professor Louise Aronson, who's at our sister Osher Center at UCSF, and it's going to be jointly hosted by the Osher Center and BIDMC's Division of Gerontology. Second, I wanted to alert you to our upcoming international conference, which we're hosting, that's titled The Science of Tai Chi and Qigong as Whole Person Health. It's going to take place here at the Harvard Medical School and Brigham Women's Hospital over 2 days in person on September 18th and 19th this year. You can learn more about this exciting event and register for the conference. And the platform is currently open for receiving abstracts, scientific abstracts that you can propose. You can get to that through our website, oshercenter.org. There's a link to the specific portal for that conference. Finally, you can learn about other programs in addition to this one, look at all of our archive grand rounds, including this one, which will be up in a few days, and even make a philanthropic donation to support our programs at oshercenter.org. So thanks again to everyone for joining us today, and special thanks to our presenters.